Tonight, a patient walks in and his skin turns blue. Staff gasp because monitors show oxygen numbers, still looking normal. His lips darken, yet he speaks clearly and feels scared. Doctors suspect hidden hypoxia and rush him into triage. This case is methemoglobinemia, a terrifying blood chemistry failure. Red cells carry oxygen but cannot release it to tissues. Pulse oximeters mislead because methemoglobin absorbs light. Strangely today, every minute matters while organs starve, despite reassuring readings. Someone draws blood, and it looks chocolate brown instantly. That unusual color signals oxidation inside hemoglobin molecules. Blue skin worsens as headache, dizziness, and breathlessness grow rapidly. The team searches for triggers before damage spreads. Many cases start in emergency rooms. After chemical exposures, hospitals see blue lips with normal lungs and clear X-rays. Dental clinics sometimes trigger it. After numbing sprays for pain, benzocaine gels and sprays can oxidize hemoglobin fast, within minutes. Lidocaine can contribute too. When doses are high or repeated, industrial workers risk exposure to aniline dyes and nitro compounds. Food processing uses nitrites for curing meats and preserving color. Rural well water may contain nitrates from fertilizers and runoff. Babies are vulnerable because enzymes reduce methemoglobin more slowly. This risk is called blue baby syndrome in old reports. Even household cleaners can act as strong oxidizers during accidents. Doctors ask about products, workplaces, foods, and water sources carefully. Normally, hemoglobin iron stays ferrous and binds oxygen efficiently. Oxidizing agents convert iron to ferric, creating methemoglobin rapidly. Methemoglobin cannot carry oxygen properly and blocks release downstream. Blood still holds oxygen, but tissues cannot access it. Well, this mismatch creates cyanosis without classic lung failure signs. Patients feel short of breath, weak, dizzy, and sometimes nauseated. Skin appears slate blue, especially around lips, nails, and face. Doctors may hear clear lungs and see normal breathing effort. Yet, the brain senses suffocation and triggers intense anxiety fast. Severe levels cause confusion, seizures, coma, and cardiac arrest. Some people have genetic enzyme issues, raising baseline methemoglobin. Most cases are acquired from drugs, chemicals, or contaminated water. Pulse oximeters use two wavelengths to estimate oxygen saturation. They assume only oxyhemoglobin and deoxyhemoglobin absorb light accurately. Methemoglobin absorbs both wavelengths and pushes readings toward 85. Numbers can look stable, while the patient looks worse. Arterial blood gas may show normal oxygen pressure anyway. That measures dissolved oxygen, not delivery inside red cells. Clinicians notice a saturation gap between tests and appearance. Co-oximetry uses multiple wavelengths to separate hemoglobin species. It measures methemoglobin percentage and confirms diagnosis quickly. Labs report results, while doctors treat and remove exposures. If co-oximetry is unavailable, suspicion must guide actions. Trust the blue lips and brown blood more than screens. Physicians noticed blue patients centuries ago with no explanation. In the 19th century, doctors described brown blood in reports. Scientists linked cyanosis to altered hemoglobin in labs. They learned oxidation changes iron state and reduces oxygen transport. World War-era chemistry expanded knowledge of industrial oxidizers. By mid-20th century, clinicians recognized benzocaine cases frequently. Co-oximeter development enabled direct measurement of variants. Toxicology grew as a specialty, guiding diagnosis and antidote use. Emergency medicine adopted protocols for cyanosis with normal lungs. Public health mapped nitrate well outbreaks in rural communities. Regulators improved labeling for anesthetic sprays and oxidizers. Yet rare cases still surprise teams during routine procedures. Nitrates convert to nitrites and oxidize hemoglobin. Contaminated well water is a classic source. after fertilizer runoff. Cured meats can contain nitrites that rarely trigger susceptible people. Medications include dapsone sulfonamides and antimalarials, sometimes two. Topical anesthetics like benzocaine are common culprits today. Throat sprays for procedures can deliver high doses quickly. Local anesthetic overdoses increase risk during dental and endoscopy visits. Industrial chemicals like aniline nitrobenzene and chlorates are dangerous. Even fire smoke can include oxidants, worsening oxygen delivery. Clinicians ask about procedures' new creams and workplace exposure. They also consider inherited enzyme deficiencies and hemoglobin variants. Finding the trigger prevents rebound after treatment and discharge. First, doctors assess airway breathing circulation and start oxygen. They check lung sounds, heart rhythm, and blood pressure carefully. Next, they look for blue discoloration, not improved by oxygen. They order arterial blood gas and request co-oximetry urgently. Blood drawn appears brown and fails to redden on air. A saturation gap appears when oximeter differs from blood gas. Teams review medication lists, especially anesthetics, antibiotics, and oxidizing drugs. They ask about well-water cured meats and industrial work. If symptoms are severe, they treat before labs return. Poison control can advise dosing and exposure management steps. Continuous monitoring watches mental status, seizures, and cardiac instability. Documentation helps prevent repeat exposure in future procedures. Primary treatment is stopping the oxidizing agent immediately. Supportive care includes oxygen fluids and warming if needed. For significant levels, clinicians give methylene blue intravenously. It acts as electron carrier, restoring hemoglobin to working form. Patients often improve within minutes as skin color returns. Dose is weight-based and repeated if needed. However, G6PD deficiency can cause hemolysis. After methylene blue, doctors screen history and consider testing when risks exist. If methylene blue is contraindicated, vitamin C can reduce levels slowly. Severe cases may need exchange transfusion or hyperbaric oxygen. Continuous observation ensures symptoms resolve and methemoglobin falls safely. Discharge includes avoiding triggers and follow-up promptly. Prevention starts by testing private wells for nitrates regularly. Families in farming areas should treat water and monitor infants. Clinics should limit benzocaine sprays and follow dosing guidelines. Staff must recognize cyanosis that does not respond to oxygen. Workplaces using oxidizers need ventilation, training, and protective equipment. Food producers control nitrite levels to meet safety rules. Emergency departments keep co-oximetry available for unexplained blue cases. Education reduces delays when pulse oximeters mislead. Patients should report prior episodes before surgeries or dental work. Medical records should flag reactions to anesthetics and oxidizers. Fast recognition turns a frightening mystery into a solvable emergency. Knowledge protects communities from hidden hypoxia fear. Remember, the blue patient was not freezing or suffocating. He was experiencing chemical hypoxia behind reassuring numbers. Methemoglobinemia changes hemoglobin, so oxygen delivery fails silently. Pulse oximeters can misread, and blood gases confuse too. Co-oximetry reveals the truth. By measuring methemoglobin directly, triggers include nitrates, nitrites, benzocaine, lidocaine, and industrial oxidizers. Chocolate brown blood is a clue clinicians never forget. Methylene blue can rapidly reverse the dangerous process. History shows science turned mystery cyanosis into clear steps. Settings include hospitals, dental clinics, factories, farms, and rural wells. If you see this footage, remember, screens can be wrong. Stay curious. Medicine hides terrifying puzzles in plain sight.